Hello, everyone. Welcome to our October session of our Mobile Health Learning Series, where we're talking about funding your mobile unit. My name is Cindy Manginelli, and I'm the Director of Community Engagement with the National Healthcare for the Homeless Council. And we're really glad that you're joining us here today. Many of you may have joined us last month when we did a series in September on safety and security for mobile health units. And then today and a week from today, we're going to be looking at different funding options, creative options for funding, building a business model, and some policy updates too that will inform how you can bill for services. As I mentioned, I'm with the National Healthcare for the Homeless Council. If you're not familiar with the council, we are a national training and technical assistance program. We do education, advocacy, policy work, things like webinars, publications, just tons of resources on our website, which you'll see there at the end of my email address, nhchc.org. I would encourage you to go and check it out. Lots of information there about mobile health, but also kind of all things at the intersection of healthcare and homelessness. We're also really happy to welcome those of you who are here through our friendship with the Mobile Healthcare Association. And we've been very happy to partner with them and brainstorm with them around resources that we can provide. Today's session is funded by the Leon Lowenstein Foundation, and we are really happy to partner with them in this and really grateful for their support. I'd like to introduce my colleague today, Katie Lee. Katie, you want to introduce yourself?
Absolutely. Thank you so much, Cindy. Hello, everyone. My name is Katie Lee. I am a clinical social worker on the policy team here at the National Healthcare for the Homeless Council. I am the clinical policy manager. And prior to joining the council, I had the great opportunity and privilege to be a part of the Healthcare for the Homeless in Baltimore, Maryland, which is where I'm located, and had the opportunity to get our mobile clinic off the ground there. So I come to you with that experience today and really looking forward to this conversation and the importance of keeping those mobile clinics out into the community by securing and thinking of ways to keep them funded.
Thank you, Katie. I'm really, really excited to have Katie with me today. And then our agenda today is we're going to talk about billing for services and creative options for funding mobile health. And then Peter's going to join us at the end and talk about what this actually has looked like in their mobile unit and kind of give you an example of some different ways that you can apply what we've talked about. So as I mentioned, a week from today, the same time, we'll be having our second session in this series. And then beginning on October 27th, we have a series of 4 Lunch and Learn on the Go series on mobile health, where we will be featuring a different mobile health unit every week. They'll just kind of give us an overview of what they do, how they're funded, who they serve, how they staff, all of that. And so we will send the link for that out to everyone who registered for this session today as well. So more information to come from us. When you get the recording, you'll get that as well. So Katie mentioned her background in mobile health. My background is primarily in direct services as well. And when I think about street medicine or mobile health, and I stop and kind of think about it and think about why we do it, I always think of the same client first, who was a gentleman named Dan that I met. Dan was in one of those situations that we see a lot here in Tennessee. I'm calling from Nashville, Tennessee, where our headquarters, our main office is. And in Tennessee, when we encounter people who are camping, very often it will look like this. It will look really, really rural. You'll feel like you're in the middle of nowhere. And Dan's camp was that way. Dan's camp was also, this picture reminded me of him because it was very structured. It was very well tended. He had a nice campfire. He had built a bed for himself using logs that he'd cut. I mean, it was very, very well put together. But when you looked all around, you didn't see anyone else. But you could walk on this little sort of animal trail for 10 minutes and you'd be kind of in a downtown kind of area with you kind of think of it as an urban area. So he was kind of experiencing urban and rural homelessness at the same time. I was introduced to Dan. Dan would go to he lived outside here. He'd lived at this camp for about 10 years. And about 2 days a week, he would go to a Dollar General and he would unload their truck for them early in the morning, and they would compensate him. And also he could, he would get different supplies there. I was introduced to Dan by someone who worked at the Dollar General who had talked to an outreach worker because Dan appeared to be really severely injured. And so I went to see if maybe he could qualify for Medicaid or Choices program, something like different programs we have here in the state of Tennessee. And that was how I was introduced to him. When I met Dan, he eventually kind of told me a story. And 10 years earlier, he had been a successful businessman. He was in his mid 30s. He was married. He had a nice home. He had a nice car. And one night, he and his wife went to a party and with his sister-in-law, with his wife's sister, and they got in the car and they were all intoxicated. And he just missed a turn and he went right over a bridge and his car just flipped over the bridge. And the next thing he remembered, he woke up in a hospital and he was told that his wife and his sister-in-law had both passed away in the accident. And he was just devastated. He was supposed to have multiple surgeries. I think he had one or two. He went to jail for a little while. And when he got out, he sold his house and he sold his car and he moved into the woods. And he said, I will never, ever live with people again. And you can imagine all the things he was thinking and feeling. And he'd lived in the woods for 10 years, but he had a significant limp. About every bone in his left leg had been broken in the accident. And he had not, of course, had any kind of follow-up care. And because he limped, he fell a lot and he'd fallen and he had one of the worst cuts on his leg that I've ever seen. I mean, it was terrible. So he had been referred to me. There wasn't a whole lot. He wasn't interested in any kind of real services. So I referred him to a street medicine team. The street medicine team came out with backpacks and they treated him for a few months. He was really clear he was never going to step into a hospital. The smell of the hospital, the sight of the white coats, he never wanted to see that again. That was what he was trying so hard not to think about out in the woods. So he was very clear that he would die out in the woods before he would step foot into a hospital. Very clear. So the street medicine team went with backpacks. They served him and helped him for a couple of months. Eventually, a mobile unit came to his area and he went to the mobile unit, which was a big step for him, and he received care at the mobile unit. And then I think about a year later, he was willing to finally go and actually step into a health center. So when we think about mobile health, and I think about street medicine and mobile health and kind of everything in between, I think about Dan because Dan accessed everything. He accessed street medicine. He accessed the community health worker, the outreach worker, the street medicine team, the mobile unit, and the brick and mortar building. And yet, unbeknownst to Dan, how each one of those things was funded and how they were coded and how that was explained to funders, you can imagine was actually really complicated. There's no Medicaid application or insurance application where there's a box to check that says, is your patient never going to step foot into a hospital again because of a traumatic event, right? There's no way to explain that. And with so many of the people that we serve through mobile health, that's the case. There's no way to quantify it. It's unique. That's most people step into a hospital, right? And so that's really kind of what our passion is, what our inspiration is, what our vision is patients like Dan. But as we start off today, we're going to talk about kind of the continuum of medical outreach. And Dan saw all of this, right? This is really important as we think about billing. This is important as we think about street medicine and mobile healthcare services anyway, because it's really clear to me that sometimes we're not all talking about the same things, but it's really important as we talk about billing because there are state Medicaid offices that would lump all of these things into the same category. There are state Medicaid offices where mobile health is very different than street medicine. There are insurance offices, there are funders that feel passionately about mobile health, but don't really believe in street medicine and the effectiveness of street medicine. And so it's really important. While I talk to programs all the time, I talked to a program on Monday and they call their program street medicine and what they are referring to what we would call mobile health. And so it's important to know as you're reaching out to funders, as you think about how you're going to try to bill or code, it's important to know what it is exactly that you're talking about. So we have developed this graphic and as closely as we can, we have tried to distinguish based on industry terms, the difference between these different modes of healthcare delivery. And again, there are even medical offices, hospitals, insurance companies that will use these terms differently, but we're trying to kind of identify for you so that as you are reaching out and asking for assistance and trying to find funders, what in general is the industry standard around language around this. So in general, when we talk about street medicine, we're talking about providers going out, sometimes in teams, sometimes individually, going out to where people are, and we're thinking about a backpack, right? We're thinking about medical care that's being delivered apart from a vehicle. Now, certainly, I even had someone question this last week. Certainly, the provider may drive to a location and get out and provide care, but the patient is not entering a vehicle. And that's what we would typically think of with street medicine, where the actual care is being delivered outside of a vehicle. With mobile health, we would typically be talking about medical care that is being delivered inside of some sort of vehicle. That may be a small van, it may be, a small school bus, it may be a unit the size of a tractor trailer, but medical care that is being delivered inside of a vehicle where the patient actually enters the vehicle for care. And we know that some of you probably do something in between here, a little bit of both. Now, other versions that are similar to this, but not the same, that would be very important as you think about billing and distinguishing your care would be some of these that I've listed here at the bottom. A remote clinic, when we talk about a remote clinic, we would typically be talking about a group of providers who go to a location and set up in that location. Maybe it's a gymnasium, maybe it's a parking lot. They set up for a day or for a weekend, they see patients, and then they pack up and they leave. That's typically what we would think of as a remote clinic. An embedded clinic would typically be a clinic that has been set up inside of a shelter or a day center or some other service provider. And it may be permanent, it may be temporary, but we would typically think of an embedded clinic as one that is located inside of another service agency. Typically, we think of embedded clinics as being inside of a shelter. Home health is one that a lot of times when we talk about mobile health, I think those of us who are serving people, when we think about indigent care, we don't think a whole lot about home health. I'm working with an agency where we're almost entirely focused on people who are homeless. So we don't ever talk about home health. But there are agencies that when they talk about mobile health, what they really mean is home health, that their providers or their nurses or their social workers are getting in the car and going to someone's home. And so you have to be careful that when you're talking about mobile health, those that you're engaged don't think you're actually talking about home health. And then this is new to me, but I've actually seen a lot of, when I Google mobile health and I'm doing research, very often what's coming up now is telehealth, which is not something I had engaged before. And what they mean is you're engaging health services on your mobile phone, or you can carry it around and do it. And so that's new, that I've had some people that I've been talking to about mobile healthcare, and they absolutely thought I was talking about telehealth. So as you think about funding, it's really important to be clear on what are the services that you offer or that you're thinking about offering, and how can you communicate that in a way that everyone knows what you're talking about. And so as we think about billing for services or funding our unit, we know there are different stages in mobile healthcare delivery. And pretty much from here on out, when I talk about mobile health, I'm going to be talking about healthcare services that are coming, that patients are entering a unit to receive, that they're coming into a vehicle to receive. That's what we're talking about here for the most part. So there is the initial cost of actually buying the unit, buying the vehicle, equipping the vehicle, finding the staff, hiring the staff or rearranging your staff to do that. Very often there's specific kinds of insurance that has to be purchased. You may have to pay for where you park, all those initial costs. And most people that I talk to about mobile health, that's what they're really, really focused on, is how are we going to get the unit? We worked with a lot of agencies who use their American Rescue Plan funding or special ESG funding or FEMA funding to buy a unit because they finally had this big lump sum of money that they could use, right? So the startup costs are enormous. And probably when people are thinking strategically about beginning to offer mobile health, that's really where they focus their thoughts. But the reality is, as many of you on this call know, maintaining the unit and sustaining the program can be very costly. And so we know that with the unit, you have to maintain it. It has to be repaired. I talk to mobile healthcare providers who actually have to go to another state to have their unit, even just normal maintenance done on their unit. They have to leave the state to do that. So that can be a big expense. Of course, fuel the technology that you need within it to make it viable, the partnerships you may need to create in order to keep it running, in order to keep it staffed, and then your staff. If you have staff in the mobile unit, are those staff who would normally be back in your brick and mortar building? And so are you missing patient hours, patient visits? Is your patient visit number decreasing because you have providers out on the mobile unit? And are you able to see as many patients in the mobile unit as that provider would see in the brick and mortar building? These are all expense related conversations and strategies that have to be created. And then sustaining your patient population. What kind of outreach will you have to do to make sure that patients know where you will be and what services you will provide and how long you'll be there? What kind of outreach will you have to do within the community? This was something that we focused on our safety and security sessions. But many mobile units spend hours and hours building those community friends, those community partners all around where the unit will be parked and where patients will sit and wait and gather. That can also be an expense of both time and money. How will you bill for services? How will each individual appointment be covered? And for many of you listening, that's very different than the way you will cover the cost of each appointment in your brick and mortar building. We did a research project on mobile health, and it's a little bit dated now. I've put it in the resources, but we surveyed many people who conduct mobile health, and about 48% said that the financing, the cost of the mobile unit is their primary barrier to providing services. That if they were going to close, 48% said the primary reason why we would have to close is because of cost, that it's just expensive to maintain, it's expensive to sustain. And so that's why we're having this conversation today. Some of this would, both the initial cost and the sustaining, would being able to build a business case for your model, for your mobile unit would be huge. And we're going to talk about that next week. And we're going to have a big chunk of next week's session will be around that. So we're not going to talk about that today, but I know for many of you, that will be the initial step, and the primary way by which you go out and find new funders is trying to figure out how do we prove that this helps. And so that's something we're going to talk about next week as well. So let's look, as we think about patient appointments, as we think about how we cover the cost of the unit, specifically around maybe individual patient appointments, there are some complications that arise and some things that are important to think about. One is, first of all, that you're really clear when you're talking to funders and that you understand that they're all talking about the same thing. We talked about that, defining mobile health. Another is to figure out, why is mobile health needed in your community? How is it going to help? Again, we look at people like Dan. How are we going to tell Dan's story? How do we quantify Dan's story? As we think about serving 50, 100, 200 people like Dan who all have unique stories. How do we collect that data? How do we organize it? How do we quantify it? How do we present it? Is going to be a big part of this. And that's part of what we'll talk about next week. It will be really important to be able to identify who are your patients. Who are you actually going to be serving? And how much control will you have over that? Here at the council, we primarily engage mobile healthcare providers who are serving people who are homeless, but we often talk to providers where that was their goal. But what do they do if someone walks up or schedules an appointment who is not homeless? Are they exclusively for people who are homeless? How are you defining homeless, right? How are people proving that they're homeless? I also work with mobile units where almost none of their patients are homeless. They just are uninsured. Here in Tennessee, we're a non-expansion state. So we have a lot of our citizens who aren't able to pay for insurance, and many of those are being, or some of those are being served by mobile units. And so who is your target population? Can you identify that? How will you regulate that? That's something that's going to be really important as you're looking for funding sources and considering how you're going to bill. And then what will be the income? What benefits or income are those patients? What do they have, and what are they eligible for? So are there benefits that you could sign them up for? If they had Medicaid, are they eligible for Medicaid in your state? If they had Medicaid, would that help to pay for some of these services? All different kinds of benefits like that. What do they have? What are they eligible for? How are we going to connect them to what they're eligible for if that in fact would become a source of income for us? So I know many of you serve patients who may be eligible for Medicaid in your state, but they don't have it. And figuring out why and getting them enrolled and helping them access those benefits is a whole nother issue, a whole nother staffing issue. So thinking through all of that, what services will you provide? And we're going to talk more about that, about different services and what that can look like and how that can affect the funding sources for your unit. Is your unit a standalone unit, or is it an extension? Can it fall under the umbrella of an existing health center or hospital or agency? And this will have a big impact on your billing for services as well, in various states, depending on who your funders are. Some funders will only fund more of a, sorry, my neighbor got a cat and it is just the worst. It's just got a lot of nerve, I'll tell you that. So my dog regularly interrupts things like this to remind me of the cat, but I think I'll be okay. So some will only fund a standalone unit. Some have a much easier time billing for services if they can just be seen as an extension of a hospital system or a unit. So that's important to think through too. If you are currently a standalone unit, would it be beneficial to find someone that can kind of provide an umbrella for you, or that you can kind of come under? And then, as we've already alluded to, what makes this topic just so incredibly complicated is that it's just about different in every state. Medicaid, what Medicaid will cover. I've even talked to someone last month who was saying that what mobile unit in their state went to their Medicaid office and was approved, and they're able to bill for services. And then they went to the same Medicaid office and they were denied, and they're doing the exact same thing. So that makes it really hard to talk about this. And I realized that it would be so much more helpful if we could say, complete this form, answer these 10 questions, and you can bill for services. And unfortunately, it's just not that way. We're going to be equipping you with tools, things to consider as you approach the world that you live in and the world of billing that you live in, because it is just very, very different all across the country when it comes to Medicaid and managed care organizations and what they will cover and how you bill for that. So I'm going to turn it to Katie to talk about, we're going to start looking here at some things that we're going to consider as we consider billing for services. We're going to look at some creative options, things like that. So Katie is going to talk about this next point.
Yes, thanks, Cindy. So I think overarching to this conversation really is, even before you have your unit or as you're building your unit, what is your scope of practice? What is ideally your scope of practice? What would your different staffing scenarios allow you to do? And then also, what is, and most importantly, and we'll talk a little bit about this even more, but what is the needs of your community? So in my experience in Baltimore, people got very attracted to the allure of this giant mobile clinic. It's very showy, it's pretty, it's very exciting. But we weren't just going to bring it to places where the individuals could easily access one of our fixed site clinics, not because we didn't think that they deserved to be able to access it, but the point of it was to get the mobile clinic to places where people were not accessing one of our fixed sites. And often we had to think about who we were bringing to those sites. And one thing we've learned from the COVID-19 pandemic, and that has been expanded and stretched and explored in a lot of different ways, is this use of telehealth to generate billable visits without having the physical provider on site. And so you can really structure a team that is physically located on the mobile clinic to include administrative staff, intake staff, those who can complete those Medicaid applications if you're in an expansion state, or if you're trying to do some benefit works as well. And then actually have the visit, and maybe an MA or a nurse, and then have a medical provider, an NP or doctor available via telehealth. This can really broaden the use of those medical providers who can generate the billable visits, while also having some opportunities for in-person contact. And so that building that trustworthiness with those individuals, using the staff that are on site, trying to achieve some other goals, maybe even doing blood draws and some lab work by having the MA or the nurse there, but having your provider in a fixed site where they may also be seeing other patients in person, and then really stretching those the use of the providers as much as possible. So thinking of ways to consider it then as a billable service. If within your state you have some telehealth allowances, and but also you're not entirely using and dependent upon telehealth. There's still some really great in-person trust building taking place. And so Medicaid may also cover mobile health services for those who are homebound, the elderly, other high-risk groups, even if it doesn't specifically for people experiencing homelessness or another category of individuals. So these are all things to explore within your communities about what Medicaid might cover and what types of services. You may be surprised, particularly there's a benefit here after COVID-19, the way we are looking at how that requirement of in-person care and how it exactly looks really has been stretched and explored in different ways, and presents some great opportunities for mobile clinics that weren't there 10 years ago when I first started the mobile clinic in Baltimore.
Yeah, I think the telehealth options are fascinating to consider and a really cool thing to explore too. Another thing you may want to consider as you are looking at funding your unit is establishing a sliding scale fee. And I think we could probably have entire sessions on sliding scale fees and the pros and the cons and how low does the scale go and how high does it go. And this is a big topic, but so we're going to just barely skim the surface here, but just something to think about. This is not one that I'm recommending as far as the amounts and all of that by any means. This is one off Doctors Care, Accessible Care for the Underserved, for their website, and I put that there. This is just to give you an idea of what I'm talking about and what that could potentially look like. But again, these numbers, there's nothing that I'm recommending here other than just to show you this is how it could be laid out and an example here. So if you were a therapist or a chiropractor or someone who just wanted to establish a sliding scale fee, what you would typically do is you would figure up you would look back at your last year and how much it cost you to run your office for a year. Then you would divide that by 12 and figure, okay, this is exactly what it cost me to open my doors for a month. And then you would divide your required monthly income by monthly patient total to establish a minimum. Right, here's all of our expenses. Now, realistically, how many patients will we see in a month? You would divide that out and you would say, okay, based on that, this is the average, this is the minimum of what we would need a patient visit to cost. So our patients who have more money can pay more than that, and our patients who have less money who make less money can pay less than that, and we'll kind of even out here. This typically doesn't work probably with the population that we serve, because more than likely we don't have very many patients who are on the high end who can make up for the patients who can't pay hardly anything at all. And so, but in theory, that's how you would create a sliding scale. You would consider your patient income and you would consider your patient family size as two factors that would determine, as you can see on the example there, exactly what they pay. So, so that is something, even in health centers that serve people who are in poverty or people who have very limited income, very often they will still use a sliding scale. And then some funding entities will require that you establish a sliding scale fee. And so one thing that can be problematic with people who don't have any income is how do they prove that? And that's really important if you're doing a sliding scale fee, is that everyone's going to need to come in and prove what their income is. So for people who have no income, there are a few different ways that mobile units can tackle that. One is for you to create a letter which patients sign saying, I have no income. And that's just self-attestation, right? I just sign it and you decide we're going to accept this as a proof of no income. And most funders, including federal government, local government, will accept that as a proof of no income. Another is to ask, and sometimes healthcare providers will ask for more than one of these, but another is to ask for a letter from the shelter or a service provider, the day center they visit, the place where they go to receive meals, or their shelter, that says this person has regularly received services with us from this date to this date. We believe that is because they have no income, something to that effect. The other is to have them apply either with an insurance company or with a hospital or on healthcare.gov to have them apply for benefits. And then if they are ineligible for benefits based on the fact that they have no income, it will generate a letter that says this person is ineligible based on their income. And many agencies will use that as a proof of no income as well. But things to consider as you think about perhaps using a sliding scale fee, or as you have funders that require that. So as we talk about looking at creative funding sources, and thinking about funding your work, this is a question that I think comes up for nonprofits across the board, whether you're doing healthcare or whatever it is you're doing. This is a question that you're eventually going to have to tackle, and that is, what part of my mission is flexible and what part is not? What part of what we're doing are we doing by conviction? Like, if we're not going to do this, we might as well shut down, right? What is the sword I'm willing to die on, right? Like, this is what we do. This is what we believe in. This is why we open the doors. And then what parts are, we don't have to do that. And this is going to be really important to know as you think about pursuing funding sources. And that's going to be really clear as we move forward. Because you're going to constantly, hopefully, if you have good success in finding people who are interested in funding your work, you're going to have people who come and say, we're willing to fund this, but not that. And you have to know, are we willing to do this? And how important is that? And so, of course, we talk about mission drift in nonprofit work. And this is where mission drift really kind of is forced. The issue is forced, is what are we willing to turn down money for? What are we willing to change or to alter so that we can be funded? And having that really clear in the mind of your board of directors, your providers, your advancement or development team, where there can be a lot of stress, a lot of tension that arises, is when someone says, hey, I found a donor and they're willing to donate all this money. And other people say, yeah, but we don't do that. That's not what we do. We do this, right? So this is a kind of a mission moment where you really have to figure out what is sacred to us. I work with some units that they serve people who are homeless. And if someone comes and says, well, we will fund if you will just serve people who have substance use issues. What if they're not homeless? How important is that to us? What's the sticking point for us? And do we all agree on that? And do those who are raising money understand our mission? Do they communicate it clearly? Or are we going to end up totally changing what we do? And how important is that to us? So this is a really big thing that has to be really cemented in your mind and in your heart as you think about pursuing funders, because most nonprofits will have funders. If you have really successful development efforts, and that right there's a big if, right? Development's hard. But if you have really successful development efforts, you will have money that you have to turn down, or projects that you have to turn down. And probably we've all encountered nonprofit work that was really just totally altered based on funders, based on who was willing to fund it. So this is a big thing to think about as you think about funding. So now let's think about possible funders. So this is from the How States Can Expand Healthcare Access in Rural Communities that I cite down there at the bottom. But for most of the country, mobile units are funded through private donors as opposed to state or federal funds. That's huge. We work with most of the mobile units, many of the mobile units that we work with here at the council. At least a significant part of their funding is going to come through the federal government. For most of you listening, that is not the case. If you are lining up with the statistics. So private donors are hard to find, and private donors are going to be a big part of your work more than likely. In cases where state funding is used, the mobile clinics are largely funded through state universities, particularly those with associated hospital systems. So this kind of gives you a direction to kind of point to as you're thinking about where to find more funding. So what hospitals, what university would benefit or would be able to get excited about the benefit of mobile health services in your community, in your state. Who are the big universities associated with hospital systems around you, and what are they most likely to fund, or what is the language that they speak? For most mobile units, that's where they're going to find their most success, is by starting there, statistically speaking. Also, as we think about possible funders, of course, we've talked about Medicaid. Of course, so I every now and then run across a mobile unit that just happens to find someone who's really rich and wants to fund their work, and that's always awesome when you can find something like that. Another option is to look at foundations. I've worked with some units that were funded through foundations that were formed when hospitals closed. So again, I'm in Tennessee, and we have 10, maybe even up to 12 now rural hospitals that have closed since 2010, which is just horrible here in our state. We have entire counties with no hospital. But when those hospitals closed, those funds had to be used for healthcare delivery for people in poverty. And so mobile unit, though, they can be used to create mobile units. So that may be something to consider if you're aware of a hospital that's closing or one that has, to check into those kinds of foundations. There are foundations where serving mobile health, like the Leon Lowenstein Foundation that's funding this conversation right now. Mobile health is very important to them, and they are very interested in that. So you may be able to find other foundations that this is something that they would be passionate about. And typically, statistically speaking, that will be easy. It will be easiest to do that in your own local area, to find foundations or trust funds that are invested in their local community. It's going to be a good place to start with that.
And
Katie's going to talk about staff investment. Yeah.
The other side to this is staffing. As we've talked about, we know healthcare is constantly in a crisis of having enough staff. And so the thought for many to actually create a whole new team doesn't feel possible. And so there may be opportunities here to look at the staff you have who would love to get outside of the walls of their health center, or looking within the community, who you can partner with in order to be able to provide them this opportunity to find the clients who are not coming in through their doors. And sometimes this not only can help them meet the clients that they have not been able to reach, or that they've seen once and are desperate to find again, but also it can be a change of pace and a change of setting than their normal, very busy back-to-back client system or schedule that they tend to have to operate. So when we think of having to pull a provider from a clinic and going onto a mobile unit, there's a fear of the loss of revenue as well, not just the generating the revenue in the mobile clinic, but actually looking at the loss of revenue that provider would have had they been in a fixed site. But there's also really great opportunities to invest in staff to create a disruption in that very hectic pace that they may feel in their clinic setting, to go into on a mobile clinic where there may be fewer appointments, but they can still be generating some revenue. And so thinking of it as not just an opportunity to meet the clients who are not coming through the walls of healthcare facilities, but also an investment in your staff to create this opportunity for them to maybe do a little bit of administrative catch up while also seeing people. Because investing in staff burnout has a huge financial incentive for health centers and for hospital systems, because losing that provider, the amount of money that would be lost just to lose that individual and then have to be invested to find someone else, but also the staff morale there to create these opportunities where it's not just about revenue production and speaking to that mission that likely brought them to this profession and wanting to serve a community who isn't able to walk through the doors. Now, this isn't for all providers, but many get incredibly excited to be able to step outside of those walls, or to we're going to talk a little bit next about different ways to be thinking of what you actually do while on the mobile clinic and who is in that space. So we'll talk a little bit more about ways that you can create excitement within the staff that is available to you, to be creating a really quality service in the community with that through that mobile clinic.
So in that vein, we're going to kind of think now creatively about ways that we can lower costs and potentially help to offset some of the costs, but also help look at creative ways to fund the unit. One is to think about volunteers. And I know that using volunteers can have its own complications. Will they show up? What kind of insurance will they have to have? How will we maintain, proof of their certification, that their license and everything is up to date? So I know that can be tricky. That can cause its own issues. But there are a lot of mobile units that use volunteer providers, volunteer nurses, volunteer staff to set up their waiting area or their intake area. Volunteers can be a huge way that you reduce costs. I know some communities, some of this happened during COVID. Some of this already existed in some places, but I know that this was more focused during COVID and in the worst parts of the pandemic, that there were groups of retired providers that were formed. I was with one group in the north that they called it like the Red Coat Brigade or something like that, because they were all issued a red coat. But they were retired providers who gathered together because they still wanted to they wanted to have an impact in their community. So what would that look like? Are there groups like that in your community that would be interested in serving on your mobile unit? At all different levels, volunteers can make a big difference. Same thing with students and interns. And again, I know when I say that, some of you are going, oh, because I know that can also cause, that also causes more work sometimes. But students and interns can help to reduce costs. And there may be, as we mentioned before, universities that are willing to partner with you or willing to provide funding for your unit because you are willing to use it as a teaching place for their students, or a place where internships can be completed. So there can be all kinds of benefits there from using students and interns. Katie?
Yeah, so special days events, these can be incredibly exciting for communities. It can be something you can often get somebody to sponsor, but also you can think of things that are particularly high billable. So offering a women's health day. So having providers who can come and do pap smears or women's wellness exams, maybe even doing for states that allow this long-acting contraceptive medications right on site. These are things that mobile clinics allow, that we talked about earlier, that street medicine outreach often find it more difficult because of just the lack of privacy that's often available in those sites. Not impossible, but often more difficult. And somebody might prefer coming into a clinic setting, which can be created right in the mobile clinic. These can be things that you do with very high volume because they are pretty time specific. You might not be offering like a broad, what do you need to take care of today? Can be very, very specific, but can increase, it could have very high billable options for that day, which can also then be a counteraction or a counterbalance to a day or a site that you go to that may not generate as many billable sessions. And one thing that I encourage everyone who is looking at what is a reasonable number of billable encounters during a mobile clinic session is to not base that expectation off of traditional clinic sites. So when you're exploring what would be a reasonable or an appropriate scale to expect, really being thoughtful of that, it is not going to look the same as it is in a traditional four-wall clinic. And if it's all right, Cindy, I'll touch upon some of these other things. Looking at things that funders are interested in. So case management, housing, substance use services, crisis intervention. These may be services that for many health centers are not directly billable themselves already. So offering them in a mobile clinic, it's not viewed as lost revenue, but in fact is something that many communities, this is where you can really learn from your hospital systems, particularly the emergency department. Who are they seeing as their high utilizers? Who are their frequent flyers, or they're the cases that keep them up at night because they're just not able to actually meet the needs they have. Providing services that meet those individuals can build an opportunity for investment from outside providers or outside large systems. And certainly it would be remiss not to talk about vaccines, disease-specific issues, such as if you have an outbreak of something within your community, HIV, hepatitis, really great opportunities to bring very targeted care with a whole much broader array of services than you would if you were just dependent upon what you could carry in a backpack. The other is to actually talk to those community partners and find out who they're seeing, these people who might be donors. They could be really important relationships to make. Churches very often will open their parking lots to you and provide other either direct monetary resources or providing some of the things that are traditional costs for you by then meeting their community where they are at. So churches often will provide a meal program on if you had your mobile clinic there on the days that they do that. They might then offer to have you park your van in their parking lot, and that could be a really alleviated costs. So really great opportunities to thinking outside of the box for what types of donors and interesting partnerships that can continue on your mission or that you could help them meet their mission. It's a great way to speak to what drives those organizations and where they spend their money. So we talked a little bit about this. These special day events can really matter, and also thinking that it should inform where you bring the mobile clinic. So when you set up that schedule, really thinking about if you are hoping to target a certain community, making sure that the mobile clinic goes where people who might want to access that service actually are located, and that you're going at a time that is convenient for them, not necessarily just based on a traditional schedule. There's a reason they're not getting into other fixed site healthcare settings and often access the emergency department because that's the one thing that's open 24 hours a day. So as I said, kind of balancing that schedule, looking at high volume days, thinking of visits that would create larger revenue opportunities or more visits with less outreach work. And then maybe having busy days like that, and then that will make it more manageable to afford days at sites that are incredibly important, but might have lower volume numbers.
All right, and so there we have some resources that you can look at too. And all of these were referenced there too. So I really would be interested to hear, like Peter to introduce himself, and then have you hear from someone who's actually navigated this and kind of had to think through this. Peter, we'll go ahead and turn it over to you.
All right. Well, this has been a wonderful overview of key concepts and important factors related to mobile health. Very well done. So my name is Peter Wood. I'm the Vice President of Planning and Government Affairs at Community Health of South Florida. We're a community health center, a federally qualified health center serving the southern half of Miami-Dade County and all of Monroe County. And we celebrated our 50th anniversary last year, so we've been around for a while. In 2019, we acquired a beautiful, big 40-foot mobile medical van with the help of HRSA dollars and direct relief dollars. And, it takes a while to get those things ordered and manufactured. So lo and behold, in 2020, kind of right in the thick of COVID-19 pandemic, we received our mobile medical van and rolled it out to the community, which had some pros and cons. Initially focused on essentially 4 days a week, focused on public housing sites. And there's a backstory behind that, but it made a lot of sense for us. And then the 1 day a week focused on individuals experiencing homelessness. And the unit has been staffed with a nurse practitioner, 2 medical assistants, a driver, and an outreach team that is sort of not part of the mobile medical van staffing, but supports the mobile medical van staff. And I think it's important to note that we have been trying for quite some time to hire a mental health practitioner on the mobile medical van, but have not been successful. That's been a real challenge for us. After 2 years of doing that, so 2000 and 2021 up to the present point, in that scenario, we've recently switched gears as a result of receiving 2 grants. One grant was from the Florida Department of Health, which supports our mobile medical van services in a particularly high need neighborhood in southern Miami-Dade County. And then we also received grant funds from the state legislature to provide healthcare services into a high need neighborhood in central Miami-Dade County 4 days a week. So so that's been a sort of a transition, a pivot point for us from the first 2 years of a mobile medical van implementation. So during those first 2 years, we've tried to bill and generate some level of revenue in a very similar fashion as to the billing process in our health centers, our community health centers. So, you know, for those individuals with insurance, we've handled that with their third-party payer. For those who are uninsured, we've charged them on a sliding scale basis based on household income, like was discussed earlier in the presentation. Keep in mind that for those who are unable to pay, patients are asked to pay what they can, when they can, and no one is denied services. And I think it's very important to note that over this past 2 years, the mobile medical van services have been heavily subsidized by our organizational reserves. We, have not been able to generate the kind of patient revenue to cover the full costs. Now, with with the grant, what we'll do is we'll suppress charges or billable charges on a designated set of services because those will be covered by those grant resources. But those services that go above and beyond those set services will bill in the same way that we do that I referenced earlier on a sliding scale basis. And that, that's a very quick overview of our mobile medical van services. I mean, I think that I've been around the business long enough to know that, they really do provide or enable an organization to do things that can't be done out of brick and mortar platforms, if you will. But it comes with another set of challenges, and I think it's up to those who have this kind of mission to be able to think through these issues the best way we can. I think I'm a big proponent of partners and being able to conceptualize and develop a mobile medical van project or initiative with as many partners as possible, because a lot of it is based on how many people you can bring in and the level of utilization of the services. I mean, it's helping out nobody if your mobile medical van services are poorly utilized, right? So I think one of the big boxes to check is, how do we make sure those services are utilized to a significant extent? And keep in mind, in terms of those benchmarks, I mean, we begin services. We're now beginning to provide services at 10 a.m. and then we leave that site at 4. That's the only way we've been able to pull off doing, paying our staff without going into overtime, right? They come in at 8:30, get everything set up, go to the site. They're up and running by 10. They provide services until 4, and then they come back, have to deal with all the, the issues of reporting and putting things back together at the home site, if you will. So that also restricts your hours of operation. Anything that you think it would be helpful for me to touch on that I haven't touched on yet?
No, that's really helpful. That's I think that's a lot of important things to think through. I think the utilization point there is huge. We all know units probably that have purchased the unit and rolled out and no one came, and so it doesn't matter how well staffed you are or what your funding strategy is if no one comes. I think it's a really good example too of how when your funding source, when you had a new opportunity in funding, you changed what you did still within your mission, which is awesome. And then I had not thought about hours too, and how you structure your day is going to be really important with that too. Thank you so much. That's very helpful. Katie, anything you want to add before we close out today?
I just really appreciate the drive that mobile medicine is not necessarily about revenue, but really about living out our mission in broader ways, and really kind of viewing it as the priority of, certainly we need to keep the lights on, and it is not helpful if you are not seeing people. I really appreciate Peter's point there of, like, it is useless to have these very large vehicles that are not seeing the people who need services. But recognizing that there are really important ways. This is a great question. To accessing, encouraging people to access mobile units in poor weather. So I'll touch upon that in just 1 second, but just that this is really a way, can speak to the philanthropic side of organizations, of businesses, can meet the needs of communities that might be experiencing some frustrations, whether it be with an encampment site, or, you can really build some community trustworthiness and collaboration if you think about ways to bring your mobile clinic to places where people are not getting into brick and mortar locations. And just to touch upon this question in 30 seconds, the weather is a really interesting one, because certainly in many areas can be particularly challenging. I think the few things that we did in Baltimore, one thing was we actually added the addition of an awning over the door, the entrance door, a retractable awning that made it so it actually created almost like a little lobby there. We had an inside lobby, but there's only so much space you could do, and especially with COVID protocols and wanting to be respectful of HIPAA. So that can be really effective in creating that space, and offering warm things or cold things in the respective weather, having some of this is something that we learn on outreach, and we know to be true in any location. Investing in coolers that'll allow you to bring hot chocolate or coffee. Think of those giant, like, Gatorade things that coaches get dumped on them after the end of sporting events. Those can be filled pretty inexpensively with something hot or cold that can be a very good incentive for people, as well as small little snacks still go a long way. There's as long as you don't need to have fasting blood work, or that can be a reward at the end of it. Otherwise, they can be really great, or you have just really thrown off somebody's blood sugar for the day.
That's a really good point. So many good points in the chat and questions. Of course, we're out of time, and we did not make this session as interactive because we had about 140 people who registered. So just a couple of thoughts. I'm going to put my email address in. We do offer technical assistance. That's part of what we do. So if there are questions, some of the questions that you posted in here, please email me and I will direct you to our technical assistance coordinator. And we are happy to connect you with other people to look for answers for your questions. Please feel free to email your questions to me and we will try to hunt down some answers. I would also encourage you, sort of a shameless plug here for the Lunch and Learns, but some of these things will be addressed because there are units who are doing this that we'll be talking to in the Lunch and Learn sessions to come. So please feel free to join us for those as well. And we will be emailing the link to those Lunch and Learn sessions to you. They should also be on our website, but we will be actually emailing the link to you as well. Thank you so much, Katie. Thank you so much, Brandon, our technology manager who offered technology support. Thank you so much, Peter. That was so helpful. I really appreciate you joining us today. Please feel free to email me and to join us next week. Everyone have a good weekend. Thank you. Oh, evaluation poll. Yes. Thank you, Brandon. Sorry. Please fill out this poll. We have to have the poll to prove that we met and to also know what we could do better next time. So please fill out the poll before you head out. Thank you so much, everyone.